Okay.
Okay. Okay, so we are going through the week 6 content for both Dr. Saravanan and Mrs. Reeves' course. We're going to start with chapter 25. This is your antidysrhythmic drugs. So these drugs are going to cover dysrhythmias such as tachycardia, bradycardia, premature atrial contractions and ventricle contractions, aflutter, AFib, ventricle tachycardia, VFib, heart blockers, and SVT. It is really important to know your general characteristics and severity when it comes to choosing the drugs to treat these. So we're going to start with sodium channel blockers. This is going to be your quinidine, procanamide, and lidocaine. So these are used by decreasing the depolarization and automaticity and increasing ventricular fibrillation threshold, so making it harder for your heart to reach the point of having VFib. So an indication is going to be for acute ventricular dysrhythmias. Some contraindications that you have are if you are allergic to that medication, the patient is in bradycardia, they have a heart block, congestive heart failure, hypotension, shock, a fluid and electrolyte imbalance, or renal and hepatic dysfunction. And then some side effects that you can see with these are going to be affecting your central nervous system, so some dizziness, fatigue, and slurred speech. You might also see nausea and vomiting. They can trigger other dysrhythmias. You also want to watch for respiratory depression, rash, hair loss, and bone marrow suppression with these. So for nursing management, you're going to monitor using EKGs. You're going to watch for hypotension, and you're going to watch for those changes in level of consciousness. When it comes to beta blockers, this is going to be your metoprolol and propranolol. It's easy to remember them through the LOL ending. So the action is blocking the beta receptors, and it works to decrease your heart rate, cardiac excitability, and the cardiac output. So some indications are SVT and PVCs. Contraindications with this medication is if the patient has bradycardia, there's the presence of an AV block, shock, heart failure, asthma, and respiratory depression, pregnancy, lactation. You're going to use caution in those with diabetes, and then thyroid, renal, or hepatic dysfunctions. And then the side effects of these are going to be dizziness, insomnia, fatigue, hypotension, bradycardia, AV block. It can also worsen an AV block if they've chosen to use it in someone with a minor AV block. Bronchospasm, nausea, vomiting, anorexia, alterations in glucose. That's why it's important to use caution in those with diabetes. And it can also interact with rapamycin, which is a calcium channel blocker. So some management things that you want to look for are monitoring that heart rate and blood pressure. You're also going to monitor an EKG and glucose for hypoglycemia. And then you're monitoring for hypotension because beta blockers can also be used to decrease blood pressure. You're going to teach your patient to measure their heart rate and then to rise slowly when they are in a sitting position or even from a lying to a sitting position. That's where you're going to see the hypotension occur. And you're going to teach them to report signs and symptoms of heart failure. So to watch for daily weights and making sure they're not gaining more than 2 to 3 pounds in a week or 3 to 5 pounds over 2 days. And then you do not want to use these in patients with asthma. For potassium channel blockers, the most common one is amiodarone. So this works by blocking the potassium channels and slowing the outward movement of potassium from the cell. So indications for this are life-threatening dysrhythmias and maintenance for VTAC, VFib, AFib, and A-flutter. It's going to be contraindicated when the dysrhythmia is not life-threatening. You're going to use caution in those who are experiencing shock, hypotension, respiratory depression, or a prolonged QT wave. You also are going to be very cautious in those with a renal or hepatic dysfunction. Side effect-wise, you can experience nausea and vomiting, weakness, dizziness, another arrhythmia, pulmonary toxicity, thyroid dysfunction, vision impairment, and then you want to watch for interactions with digoxin and quinidine. So nursing management for this, you're going to use caution in a patient who has a heart block, so you're going to make sure your patient does not have that. Those who are pregnant, lactating, and you're going to monitor for vision changes. If your patient's experiencing any palpitations, watching the skin and the split of the eyes for jaundice, reporting abdominal pain, teaching your patient to avoid the sun and to take this medication with meals. When it comes to calcium channel blockers, we have diltiazem, verapamil, amlodipine, and nifedipine. So to remember diltiazem and verapamil with being calcium channel blockers, you can think about Valentine's Day because they start with V and D. So your action here is blocking the calcium movement across that cell membrane, which depresses the action potential and slows the conduction of those electrical signals through the AV node. So indications is second-line drug for SVT and angina. Some contraindications are allergies, having a heart block, renal hepatic dysfunction, pregnancy, or lactation. Some common side effects are going to be hypotension, arrhythmia, GI upset, skin reactions, headache, and dizziness. And with these, you really want to monitor for orthostatic hypotension. This is a big safety concern. And you're going to monitor for the presence or new onset of dysrhythmias. So adenosine, if you have Miss Amy for your instructor, you will know that adenosine is her favorite drug. So the action is to decrease the automaticity in the SA node and slowing the conduction in the AV node to prolong the PR wave. So indication is SVT, and it's used as the rescue drug. Some contraindications are going to be that it interacts with methylxanthines and dipridamol. So side effects is that you may see asystole for a few seconds. And then there's going to be sinus bradycardia, dyspnea, hypotension, flushing, and chest discomfort. You are essentially stopping the heart when giving this drug to convert it back into a normal rhythm. So nursing management is that it has a very short half-life of 10 seconds. So that hopefully will cause minimal side effects, and you do want to monitor an EKG after giving this drug. When it comes to digoxin, it works by slowing calcium from leaving the cell and prolonging the action potential, slowing the conduction and the heart rate while increasing that contractility of the heart muscle. So indications are for heart failure, AFib, and A-flutter. Some contraindications here are an allergy, if your patient's experiencing VTAC or VFib, a heart block, have had a recent MI, renal insufficiency, fluid and electrolyte imbalance, and bradycardia. Side effects consist of other dysrhythmias, a headache, fatigue, vision changes, anorexia, nausea, vomiting, and diarrhea. Nursing management is that you're going to assess for toxicity. So toxicity occurs when you're giving digoxin in a patient who has a low level of potassium. And if your patient has a higher level of potassium, that digoxin level is not going to be in its therapeutic range, so it's not effective. Before giving digoxin, you want to make sure you count a radial pulse for a full minute, because you need to let the healthcare provider know if it is greater than 120 or less than 60. And then that therapeutic level is going to be 0.5 to 2. And when it comes to digoxin toxicity and vision changes, green halos is one of the biggest signs for those vision change. Okay, so some key takeaways for the antiarrhythmics is going to be that any antidysrhythmic can cause another dysrhythmia or arrhythmia. And then you want to know which drugs are used for which dysrhythmias, because you're not going to use lidocaine on someone who is going into AFib necessarily. That's a ventricular dysrhythmic treatment. When it comes to major side effects, you have bradycardia, hypotension, hypoglycemia, and bronchospasm for your beta blockers. And you'll see asystole and adenosine. And then signs of digoxin toxicity and knowing that normal therapeutic level is important.
Okay, so chapter 28 is our diuretic drugs. So first we have our loop diuretics. The most common one is furosemide. It's also called Lasix. That's probably what you're going to hear most of the nurses in the hospital call it. It's for heart failure, hypertension, and then hepatic and renal disease. It blocks the, oh my gosh. Abby, why am I having problems right now? Thank you.
I think it's the chloride pump.
Oh, yes, the chloride pump in the loop of Henle to cause sodium and chloride reabsorption. So loop of Henle is down in your kidneys. This is an oral and an IV med. In the hospital, you're mostly going to see it IV. If people are taking it at home, it's going to be oral, obviously. You're going to watch for any allergies, electrolyte imbalances, anuria, renal failure, hepatic coma, gout, and diabetes. And then you need to take caution in SLE.
So I'm just going to add in with this one, you need to monitor your potassium levels before you're giving it.
Yes, that is a very good point. So some side effects, hyponatremia, hypochloremia, dehydration. That's a really common one, is dehydration. You're going to have pretty much low levels of just about any electrolyte is common. It does interact with digoxin, so you're not going to give it with that one. That's important. It is potassium sparing. Or no, wait.
No, this one is not a potassium.
You should not know.
Potassium with this.
Yes. I'm so sorry. I think the medications that it interacts with are in the side effects section. That's why I got confused.
Yep.
Yes, so it interacts with anticoagulants, case-sparing diuretics, lithium, antihypertensives, NSAIDs, and digoxin. There we go. That was why I was like, this is not case-sparing. So for your considerations, you're going to make sure you're getting a baseline weight. You want to see how much, they're going to be going to the bathroom a lot of output with their urine. You want to make sure they're not losing too much weight, not gaining too much weight if they're, if they tend to retain that water. Really important. Again, you're going to be monitoring those electrolyte levels, your BUN, uric acid, glucose, all of your really important ones for electrolytes. You have to watch for dysrhythmia. There can be hearing loss. And then orthostatic hypotension again, like Abby mentioned earlier. And then you're going to take these diuretics in the morning. And again, just make sure that you're really moving slowly, not doing anything too fast, because it can make them dizzy.
So with that hearing loss, that is mainly for your IV administration of Lasix. If you push that too fast, you can cause hearing loss in your patient. So it is very important to follow the administration recommendation of pushing Lasix over 4 minutes and no more than 4 milligrams in 4 minutes.
Mhm. All right, so now we have thiazide diuretics. A couple of examples, chlorothiazide. This one's for chronic heart failure, liver, renal disease, hypertension. It's going to block that chloride pump and it's going to keep the sodium and chloride in the pump to be excreted in the urine. So it's some contraindications, obviously, if they have a thiazide allergy, electrolyte imbalance, fluid imbalance, you're not going to give them a diuretic. And then renal and liver disease. It's, we're using it for them, but it's also kind of contraindicated in them. It's really a case by case basis. And you're really looking at, side effects and the risks versus what the patient could get out of it. For side effects, hypokalemia, altered glucose, alkalotic urine, decreased calcium excretion. It does interact with digoxin again, just like the loop diuretics did. And then for your nursing considerations, baseline weights and labs, you're going to monitor those fluids and electrolytes. There is an increased risk for the lithium toxicity. So you need to watch that level as well. And then again, just monitor your levels, BUN, creatinine, glucose. So potassium sparing diuretics, that's your spironolactone. Oh my goodness. This is for patients who are at risk for hypokalemia. So they're usually given with a loop or a thiazide diuretic, blocks aldosterone in the distal tubule. It is also an antihypertensive. Causes a loss of sodium while retaining potassium. That is important. Keeps your potassium with this one. So it's a potassium sparing diuretic. So it's contraindicated, obviously, for allergy, just like every med. Hyperkalemia, renal disease, and anuria. Side effects, again, you can have too high of a potassium level. You can have some GI disturbances, weakness, impotence, amenorrhea, toxicity with that lithium or digoxin levels. So again, you're really watching those levels with your diuretics. It does interact with salicylates. Other than that, again, you're just monitoring your labs. And osmotic diuretics, this is your mannitol. It's for increased ICP or acute renal failure. It pulls water into the renal tubule without sodium. It is contraindicated with renal disease, anuria, pulmonary congestion, intracranial bleeding, dehydration, and CHF. Side effects, nausea, vomiting, hypotension, lightheadedness, confusion, headaches, heart arrhythmias. Is that what the HA is for?
Headache.
Oh, headache. Okay.
Yeah, it's headache. Sorry.
No, you're good. You're good. Sorry, guys. We both work on these, but then we present ones that we didn't make, and it can be confusing sometimes.
Okay, so we have let's see. we have our fluid and electrolytes. So there's a few groups of fluids. The first one we're going to start with is crystalloids. So these do not contain any protein, and they are purely consisting of fluid and electrolytes. So this is going to be your normal saline, your 0.9% NaCl, your half normal saline, the 0.45%, lactated ringers, also referred to as LR, D5W, that's a dextrose solution, and then your hypertonic saline or your 3%. So these are used by replacing fluids in those experiencing dehydration as maintenance fluids. So sometimes you will see patients just on a steady rate of normal saline. You can also see them used as mechanisms for fluid electrolyte replacement. So when giving potassium via the IV, you'll see that potassium mixed in a normal saline solution. And then they can also be used to manage different fluid and electrolyte imbalances. So if you're low on sodium, you'll see a saline solution given. These are indicated in patients who have an acute liver failure, acute nephrosis, burns, are experiencing shock, or renal dialysis. If you ever get the chance to work in or go to clinical in a section that's preparing patients for surgery, you might see LR being hanged or being hung. So you might see a bolus done and then a maintenance rate. And then some side effects are edema, worsening alkalosis or acidosis, dilution of those plasma proteins because you're adding fluid to the blood, and fluid overload. So it's really important to watch when you're giving these medications for any onset of shortness of breath with crackles in the lung bases, if there's swelling, because that could be fluid overload in your patient. And then by diluting those plasma proteins, you can also bring in edema. So our next group are the colloids. So these have protein in them. So this is going to be your albumin, dextran, and hexostarch. So they are either an isotonic or an isoosmotic. Some indications are hypovolemic shock, the rapid replacement of IV fluids, and correcting albumin levels. So if a patient comes in and they have a very low or poor diet when it comes to protein, and you see a decreased albumin level, and they have just generalized edema on them, you might see a doctor prescribe an albumin or colloid because you need to replace that level, and it works to keep the fluid in the blood versus going out into the other cavities, like third spacing almost. And then some side effects are going to be altered coagulation, bleeding can occur, anaphylaxis, renal failure, and then again, the fluid overload. So our next group is blood products. So these come from blood donations. And the different blood products you can have are your packed red blood cells. You'll see this used most commonly. You also have your cryoprecipitate, and that is going to be like clotting factors. You'll have platelets, fresh frozen plasma, and then whole blood. So blood is the only fluid that carries oxygen, and this occurs via the red blood cells. It will increase plasma volume, and it increases the oxygenation of tissues. However, blood is very expensive. So it's used to treat acute bleeding, clotting factor deficiencies, and anemia. Some side effects are incompatibility, anaphylaxis, cross-match, transmission of pathogens or blood-borne diseases. So nursing implications for fluids and electrolytes, you are always going to want to assess your vital signs. So it's important to take vital signs before starting fluids and throughout the fluids. You want to know what the baseline weight is, and then you'll want to take daily weights when you're giving fluids. It's important to monitor those INOs. You want to make sure that your patient is not retaining too much of the fluid. And then you're monitoring that infusion rate and the infusion site, because you can see infusion site reactions or impaired IV functions like infiltration, which can damage the surrounding tissue. So when you're administering colloids, you're going to administer them slowly because they can increase the blood pressure significantly. With blood transfusions, you really want to monitor for signs of transfusion reactions. A transfusion reaction can be deadly. So if a transfusion reaction occurs, you will immediately stop that transfusion, and you want to keep all the tubing that you were using when you're giving that transfusion along with that blood product, because you will have to send that back to the lab so they can double check the type and cross match that they did, or the type and screen that they had performed before sending that blood to your floor.
Okay, so chapter 36. So just some lifespan considerations when we're talking about the respiratory system and using medications for it. For children, caution in children under age 6, but do not use them in children under age 2. There are adverse effects, drowsiness, dizziness, confusion. Make sure that you're educating parents about over-the-counter medications. Encourage fluids, humidifiers, avoid triggers like smoke, and wash hands frequently. So it's for just about any respiratory, illness. Adults, we're going to assess what the patient's already been taking. Really have to be careful. Sometimes patients will take over-the-counter medications and they won't report it because they don't think that it's important, but we have to make sure we're not overdosing them. We're going to encourage non-drug measures. If they want something like a cold pack or a heat or stuff like that, we're going to try and do that while we're giving someone Tylenol. And then, take caution in pregnancy and breastfeeding, just like with every other medication. Older adults, we're going to have more adverse effects, more likely to happen with them, more likely for them to have the severe adverse effects. So make sure that you're using your safety measures. They are more of a fall risk. And then renal and hepatic impairment, make sure that you're starting at lower dose and monitoring for those patients. And then again, even regardless of the age, we're always going to educate on over-the-counter medications. Make sure that they're consulting their provider for those. So antitussives, these are your cough medications. They block the cough reflex. Benzonatate, codeine, hydrocodone. Contraindications, some patients need to cough to clear their airway. So we're not, we don't want them to not be able to cough if, it's a productive cough. And then if they have a head injury or impaired CNS. Make sure that you're taking caution in people with hypersensitivity and narcotic addictions. Again, some of them have codeine. Adverse effects, there is a drying effect. So, dry mouth, dry eyes. CNS effects, GI upset, can make people nauseous. And then with your nursing implications, make sure you're doing your respiratory assessment. Again, if it has the codeine, there can be a little bit of a suppression there, or depression. Make sure you're providing education, make sure you're checking, is their cough productive? Is it non-productive? You're going to check those lung sounds. Yeah. So for decongestants, ephedrine, Afrin, so these decrease blood flow and decrease overproduction of secretions. So there can be rebound congestion, and so you're going to make sure that you're only using it for 3 days. There can be some local burning, some lightheadedness. Some of these are medications that you are, inhaling or spraying it into the nostril. So that's why you can have some stinging. You're not going to use those medications for someone who has a lesion, like in their nose. Make sure you're checking their vitals, respiratory assessment, make sure they're not retaining urine. And then again, make sure you're doing that patient education. And then for oral decongestants, that's where we're having larger systemic effects, and they are obviously slower. So nasal steroids, Nasacort is a really common one. We don't really know what their mechanism is, but they do decrease local inflammation, which can help a lot for people with allergic rhinitis, inflammation after nasal polyp removal. Contraindicated for acute infections. You have to be careful for active infections and avoid exposure to airborne infections when they're using these steroids. There can be local burning, irritation, stinging, and dryness in the nose, which can lead to some nosebleeds. Also can have headaches and some suppression of healing. So we have to be careful if, they just had surgery or trauma. And then again, vitals, respiratory assessments, making sure you're checking their mental status, patient education, like always. So antihistamines, everybody knows Benadryl, super common medication. It blocks the action of histamine that increases secretions and narrows airways. So it's mostly used for rhinitis, angioedema, urticaria. I'm not sure how to say that. Oh my goodness. It does cause drowsiness and sedation. A lot of people will fall asleep when they take Benadryl. It does have anticholinergic effects. We have to be careful with our patients that have renal and hepatic impairment or a history of arrhythmia with this. And then again, you're just going to make sure you're checking your vitals, checking to see if they're having any of those anticholinergic effects, dry mouth. Check that renal and liver function, make sure that they're taking it on an empty stomach. You can also increase humidity in, the room to help with those secretions. And then be careful with over-the-counter drugs and alcohol, because they can interact. So that's another part of your patient education. So expectorants, so this is Mucinex, and then mucolytics is acetylcysteine. So expectorants increase productive cough to clear airways, and mucolytics increase the respiratory secretions. So it helps to clear the airway. So we're kind of loosening and then getting rid of it using these. Expectorants are used for symptomatic relief of cough and mucus, and then mucolytics are used for patients that have difficulties with clearing their airway. So that can be, cystic fibrosis, atelectasis, tracheostomies. And then again, just checking those vitals, make sure there's no lesions if we're using these. Do your respiratory assessment, obviously, because you're giving a respiratory medication. Don't use over-the-counter meds unless they are approved. And then just your normal safety measures.
Okay, so we're going to move on to respiratory drugs. And we're going to start with the beta adrenergic agonist, bronchodilators. So that is going to be your albuterol. It is an inhaled short-acting beta-2 agonist. It can be used in an acute setting or as needed. And it also has the chance to be used in long-acting or long-term control. So it works by providing bronchodilation. It's indicated in those who have COPD or asthma. Some adverse effects is that it has the sympathomimetic stimulation and CNS stimulation. You might see some GI upset, cardiac arrhythmias, hypertension, bronchospasm, sweating, pallor, and flushing. So I don't know if anyone's ever had to use an inhaler before, but most commonly you're probably using albuterol, and you might feel some like palpitations in your chest after you've used that. That can be common. So nursing implications, you're going to assess for that therapeutic effect. You want to make sure that their breathing is easing up after you have given them that albuterol. You do want to check vitals because it can cause tachycardia. You're going to assess that liver and renal function test. You're going to look for any CNS effects that might be occurring. You always want to repeat that respiratory assessment, and you want to give that patient some education, especially when it comes to safety measures when using it, that they're not misusing their inhaler. You also want to have them take small, frequent meals. Okay, so anticholinergics, you have your inhaled anticholinergic, and that's the ipratropium. So this antagonizes acetylcholine and blocks vaguely mediated reflexes, and it's used in the maintenance treatment for those who experience bronchospasms in COPD. Some adverse effects are going to be that dizziness, headache, fatigue, dry mouth, and urinary retention. You always want to remember the can't see, can't spit with any type of anticholinergic. So nursing implications for this, you're again going to assess for that therapeutic effect. You want to make sure it's working when you're giving it to your patients. You want to watch for CNS effects, dryness, any increase or decrease in pulse and BP, respirations, and then urinary output. It's very important that you're voiding before using this medication. You do want to watch that hydration status, and again, have small frequent meals and teach the patient about what they can expect. Okay, so xanthine derivatives, that's going to be your theophylline. So this works by increasing the CMP and causes bronchodilation. It is used in those with asthma and COPD. It is contraindicated in those with cardiac dysrhythmias, hyperthyroidism, seizure disorders, and peptic ulcers. Some adverse effects are going to be nausea, vomiting, anorexia, tachycardia, extrasystole, palpitations, and ventricle dysrhythmias. And nursing implications are going to be assessing those vital signs, assessing for therapeutic effect, and then making sure there's no oral contraceptive used before you're giving this. This medication is not commonly used nowadays. It is something that was used when they had no other options, and before they figured out that there are other medications that they can give that work better with less side effects. So corticosteroids, these are also going to be inhaled steroids like budesonide. So they work by decreasing that inflammatory response that occurs in the airway. They're going to be indicated in the prevention and long-term treatment of asthma, and also treating steroid-dependent bronchial asthma. You might also see these used in some cases with COPD. They are contraindicated in the use for emergency or acute asthma attacks, pregnancy, and lactation. Some adverse effects are going to be a sore throat, having that hoarseness, coughing, and dry mouth, and then pharyngeal or laryngeal fungal infections can occur. So for nursing implications, you want to assess the vitals, assessing for therapeutic effect, lesions. And then with corticosteroids, you want to taper off. You don't want to abruptly stop them. And then after you've used an inhaled corticosteroid, it's important to rinse the mouth out after. And then you're going to monitor for infection because you could see that oral thrush occur with the use of this. So leukotriene receptor antagonists are going to be like montelukast, also known as singular. So the mechanism of action here is decreasing or blocking that inflammatory response that can occur in the airway. It is indicated for those with asthma. Some contraindications are going to be someone having an asthma attack. And then you're not going to use with povidone or lactose. So adverse effects are going to be headache, nausea, dizziness, insomnia, and diarrhea. And your implications is going to be assessing for vital signs and a therapeutic effect with it. Okay.